Welcome. This is Brian Wood, Medical Director for the Mountain West AETC Project Echo Telehealth Program. Each of our weekly sessions starts with a short talk focused on issues relevant to HIV clinical medicine. The following talk was recorded live here at University of Washington. We will now take you to this week's talk.
Thanks, Brian, for that introduction. Hi, everyone. It's great to be here with you today. I'm going to be talking a little bit about Abacavir with some insights from the REPRIEVE trial, and specifically about the cardiovascular risks. I have no conflicts of interest or disclosures, and this is our usual disclaimer. If I mention any brand names or anything like that, it's just for identification purposes only. So these are our learning objectives today. Today's session was inspired by a recent paper from the REPRIEVE trial that came out in April of 2025 examining Abacavir and cardiovascular risk with respect to tenofovir. We'll start by reviewing the evidence behind Abacavir and its association with higher cardiovascular risk and what the guidelines say about that risk. And then we'll talk about the findings from this new paper. And finally, I'd love to discuss and hear from you all on your approach with Abacavir and what you all see its potential role in the contemporary ART landscape. Let's start off with a case. So you have a 63-year-old gentleman with hypertension and dyslipidemia who presents to your clinic to establish care for HIV. He has pretty well-controlled HIV for the last 10 years and has a CD4 of 359 and undetectable viral load at his most recent check. And he's currently on atorvastatin 20, losartan, and Triumeq, so Abacavir, lamivudine, and dolutegravir. He's interested in reducing his risk for cardiovascular disease and heard that Abacavir may impact this risk. So, a quick poll. Would you consider changing his ART regimen, yes or no? So, as you can probably all see, about 70% of you are thinking that you would change his ART regimen, and about 30% are saying maybe not yet, or maybe you're holding out to hear what we have to say about during today's lecture. So, reviewing the current guidelines, at least at the DHHS and the IAS USA guidelines here, they mention a few snippets here in both guidelines. In the US DHHS guidelines that was most recently updated in September, they just say that some data continue to support an association between Abacavir and an increased risk for serious cardiovascular events. And then they mention Abacavir should be used with caution or avoided in people with cardiovascular disease or known high cardiovascular risk. They don't put a specific evidence rating on this. They don't full out call out in a section like in the IAS USA guidelines from December of this year at least, and it's been there before, but from this latest iteration, it specifically calls out to say people with or at high risk for cardiovascular disease who are receiving an Abacavir-containing regimen should switch to a non-Abacavir-containing regimen if an active regimen is available. I should also point out that both guidelines removed Abacavir-based regimens, specifically talking about Triumeq, from their preferred frontline options recently. They call out specifically for this change from the difficulties potentially of getting HLA testing beforehand, but also potentially these toxicities related to cardiovascular disease risk. So, reviewing a little bit about Abacavir and cardiovascular risk, I'm sure most of you are aware of some of these, but just to review really quickly. This association was first described in the DAD study way back in 2008, and in that study, Abacavir was noted to be associated with about 2 times higher risk for MI, specifically just MI in this case, and that signal was potentially only with recent exposure within the last 6 months of starting Abacavir. But the signal didn't continue with cumulative or past use. There was a later DAD study in 2010 that also compared this to tenofovir, and it didn't find the same elevated risk of MI with Abacavir. This has since been reproduced in multiple cohort studies, observational analyses, and meta-analyses, even after adjusting for confounders, like CKD and in different time periods. However, this is still controversial because multiple studies and at least one meta-analysis did not find higher CVD risk associated with Abacavir. Some of this may have been discussed as potentially related to channeling bias, which the one that tends to be brought up is that there's a tendency for folks potentially with CKD, which is a known CVD risk factor, to be put on Abacavir, which is more renal dysfunction neutral. And that could be potentially a cause of some of the findings that we find in these associations. And then other folks have mentioned that use of Abacavir in older, more toxic ART regimens could also have been a confounder or contributing to Abacavir's higher risk of CVD. And so that kind of like summarizes the landscape of what Abacavir and cardiovascular risk. Some putative mechanisms that folks have suggested could be the cause of that is Abacavir's increased platelet aggregation and hyperreactivity and potentially increased inflammation related to white blood cell recruitment, leading to plaques. And there's been some hypothesizing that this could explain some of the timeline of exposure, like only a recent exposure leading to risk of CVD versus not. So this is the landscape. This paper, a lot of time when I was initially reading, I was like, why examine this now? Because we have so many other prior studies. And they make the case that there's knowledge gap because most of the studies that I've just highlighted are from Western European countries or high and middle income countries, and not a lot from low and middle income countries. And a lot of these were done in the time frame of earlier, more toxic ART regimens. And most of those studies did not use adjudicated outcomes, which have less risk for misclassification. And so for those reasons, they were like, great, let's do this in REPRIEVE and give a better idea of potentially the risks of cardiovascular risks with Abacavir. So this paper came out last month in Open Forum Infectious Disease. And to be clear, it's a sub-study within the REPRIEVE trial. So for a quick reminder of REPRIEVE trials, methods, and results, this REPRIEVE trial, the purpose was to investigate if statin therapy is protective for MACE, which is a composite outcome of cardiovascular events. And I'll get more into that in the next slide. But this specifically looks at MACE in folks with HIV at low to moderate risk, and folks were randomized 1-to-1 to pitavastatin versus placebo. You see the enrollment criteria there, and folks were excluded if they've had a prior cardiovascular event. So this study occurred between 2015 and 2019 in 12 different countries from around the world, including Canada, US, Spain, multiple places in Latin America, Sub-Saharan Africa, Southeast Asia, and South Asia. REPRIEVE was stopped early in 2023 due to a predetermined endpoint, finding that pitavastatin reduced major adverse cardiovascular events, or MACE, by 35% compared to placebo. And those results were published in New England Journal in 2023. For this sub-study, some additional inclusion criteria included folks had to be on an Abacavir or tenofovir backbone when entering the study, and they were excluded if they weren't able to categorize folks into one of those three buckets, so to say. They looked at MACE as well, and that comprises of MI, stroke, TIA, peripheral arterial disease, and revascularization or cardiovascular death. That was the primary outcome, just like in REPRIEVE, and in their secondary outcomes, they looked at time to the first hard MACE, which they define here. This study had a lot of detailed analytical methods, and my goal is not to bore you with that, but to kind of summarize here a little bit to help interpret the study a little bit more. They compared the risk of those primary and secondary outcomes across the three different types of NRTI groups using two different approaches. Both of these approaches had the goal to simulate, quote unquote, simulate a clinical trial using existing data, because the original trial in REPRIEVE had different entry criteria, had different intervention, all that could introduce biases and confounders that would potentially really impact the interpretation of this sub-study. And so they used marginal structural Cox models to find the time to first MACE, and they adjusted for multiple baseline clinical and REPRIEVE study factors, both baseline and time updated. And the two approaches that they used was, and these are my words, they don't actually call it this within the study itself, but the first one that I call, quote unquote, intention to treat, ignored any switches over follow-up. So any participant that came in on Abacavir and later switched to, say, tenofovir would be considered Abacavir. And then a second approach, which is what I'm calling a modified intention to treat, allowed for one switch, and folks who switched would then be censored after that switch. So, for example, if someone came in on TDF and then they switched to Abacavir later on, they would be this would be accounted for within this modified intention to treat. They would be in the TDF group, but then they would be adjusted for additional weighting to reduce bias related to switches. So keep this in mind. The Table 1 highlights here the initial results here. So because of the additional sub-study requirements, they included about 80% of the overall REPRIEVE cohort and included around 6,100 folks within the sub-study with a median time of follow-up of around 5.5 years. Over half of the folks were younger than 60, about 50 of those were 40 to 50, about a third were female at birth, and about 2/3 were non-white. Very similar to the overall REPRIEVE cohort. And overall ASCVD risk was about 80% of those had less than 7.5% ASCVD risk, and almost 90% had a CD4 count greater than 350. They do not actually include any sort of HIV viral load data in this study for me to kind of report that for you at baseline. And you can see here that the breakdown of different entry NRTIs, TDF had the vast majority of folks, around 4,200. Abacavir had around 880, and then TAF had around 950 folks. And then you can see the breakdown of their companion anchor drugs. Most folks in Abacavir and TAF groups, a little over 2/3 were on INSTIs, and about 2/3 of folks on TDF were on NNRTIs. And then for folks who switched the NRTI, most folks, about 60%, did not switch, but about a third switched, and about half of folks, if they switched before 2 years, and half after 2 years. And overall outcomes for MACE, they had about 183 events total. And then you can see the breakdown here by crude kind of entry NRTI. So about 5% of those on Abacavir had a MACE, 4% on TAF, 2% on TDF. And because of the switch, you might ask how many of those occurred on their first NRTI. About 2/3 were on their first NRTI. And here are the main results comparing the hazard ratios of MACE and other outcomes between different pairs of NRTIs across these different models. A few things I want to highlight. So these are the events here, and then different adjustment models. So this is crude. This is what I like to call intention to treat, and this is kind of the modified intention to treat. And you can see the comparisons of Abacavir versus TAF, Abacavir versus TDF, and then the two different tenofovir component versions. A few things I want to highlight. The unadjusted associations, so these none rows, suggest that first MACE does not differ between Abacavir and TAF use at entry, and both have greater hazards than TDF use at entry. I just wanted to highlight this about how accounting for confounders and biasing factors is important, and the findings are fairly different than the adjusted models. I'll be focusing on the adjusted models here, and those are the ones that are boxed in red. So overall, there's a higher risk of MACE in this first one, the primary outcome, for Abacavir compared to both versions of tenofovir. About 50% more for TAF and about 40% more for TDF. I do want to highlight that while these confidence intervals cross one, which suggests that they're statistically non-significant, overall, this may be a power thing where the overall signal do suggest that there is a potential higher risk of cardiovascular events with Abacavir compared to either version of tenofovir. But then when you look across here, there's a similar overall risk of MACE for tenofovir AF versus TDF. So a hazard ratio of around 0.9 and 1.2. And when you look at allowing for one switch, so this modified intention to treat version, there's generally increased hazard ratios, but the findings overall are less precise when you compare them to the intention to treat analysis here. And for secondary outcomes of what they call hard MACE and the components of these, MI, stroke, cardiovascular death, adjusted associations comparing Abacavir to TAF or TDF generally suggest a higher risk of hard MACE and its components. And hazard ratios comparing Abacavir to TDF were generally higher than those for TAF, except for stroke. These are the main high-level findings from this sub-study. So they conclude that the results generally align with earlier studies that I've highlighted, with Abacavir associated with higher risk of first MACE and its components compared to tenofovir, even after adjustment for relevant clinical characteristics and study characteristics. And the other thing is that, not surprisingly, TAF versus TDF had similar hazards of first MACE and their various components. A few key limitations of the study: they weren't really able to look into anchor drug interactions, so that being like INSTIs or NNRTIs, because of the level of detail that was collected within REPRIEVE. So they weren't able to address specific drug interactions with the specific entry NRTI and that impact on MACE. And they evaluated folks that were already on their specific NRTI. So, for example, folks who were experienced on Abacavir or folks who were experienced on TDF, rather than doing a new user analysis, meaning folks who were just initiating Abacavir or just initiating tenofovir DF or something like that. So just a few caveats to think about. They did look at Abacavir, how long someone's been on it and timing of it, in a poster from IAS back just this last year. And the high-level findings of this was that in adjusted analysis, including baseline regimen, meaning accounting for INSTIs or NNRTIs, both former and current use of Abacavir was associated with higher incidence of MACE, and what they found was about a 30 to 40% higher risk of MACE with Abacavir, either current or prior exposure, when compared to no Abacavir use. They don't have specific data on how long folks were using Abacavir for, but this is just saying prior exposure or currently on Abacavir, they found a higher risk for MACE. Returning to the case, would you consider changing his ART regimen after hearing these data? Okay, so that did sway some folks. It was previously a 70-30 split approximately, and now it's a 95, almost, and 5% split. Great. I'll open it up to discussion. These are just some questions to get the conversation started. We can certainly talk more about Abacavir and other parts of its effect on cardiovascular risk, but to get us started, why did you choose to change or not change his ART? How would you counsel him on Abacavir? And when and what groups would you consider using Abacavir in contemporary ART? Starting with that first one. For myself, these data really kind of helped me think about cardiovascular risks outside of just within the North America Western confines of ART, because lots of different places have different ART and access to different types of ART. And it was helpful to see that even in contemporary regimens that there's still significant risk. And the other thing is that it was really helpful to see, from my standpoint, in low to moderate risk, folks at low to moderate risk for ASCVD, you still see the signal. Some of the studies in the past, they did account for ASCVD risk level, but this contemporary cohort was specifically focused on that, and you still see a really big signal for cardiovascular risk. This study swayed me in that result.
Thank you for watching this edition of the Mountain West AETC Project Echo Didactic Series. If you like this talk, please click the red subscribe button and please check out other talks in our series. Until next time, this is Brian Wood, Medical Director, signing off.